respected chairpersons and distinguished participants. For the next 10 minutes, we will try to uncover CAP. CAP? What is CAP? CAP is a heterogeneous group of disorder defined by presence of metastatic disease with no identified primary tumor at presentation. So we'll start with a case, a 62 years old woman presenting with weight loss, multiple hepatic lesions on CT scan, core biopsy from liver shows poorly differentiated malignant neoplasm, initial lab unremarkable, tumor markers non-contributory. So this is the histology, sheets of atypical cells, no glands, no pigments, that is no melanoma, no evidence of lymphoma, no squamous differentiation. So what will be our step, or how we'll come to conclusions? So our first step is morphology, differentiate types of cancer, whether it is carcinoma or lymphoma or melanoma or sarcoma. So morphology can tell us a good information. This is a gland-forming tumor, so it is adenocarcinoma. And this is lymphoma, and this is sarcoma, spindle cell tumor, so it is sarcoma. So morphology can play an important role. Now this is an adenocarcinoma. On the left side it is well differentiated adenocarcinoma, on the right side it is poorly differentiated adenocarcinoma. And this one is squamous cell carcinoma. There is evidence of keratinization. And this is a small cell neuroendocrine carcinoma, very cellular tumor. So the next step is confirming cell lineage. So morphology can provide some clue about cell lineage, but the key player is immunohistochemistry, which can determine cell lineage. For epithelial phenotype, pancytokeratin, for hematolymphoid, CD45 or LCA, for melanoma, S100, Melan A, SOX10, at least S100 and HMB45, and if all three are negative, then we'll have to think about mesenchymal tumor or sarcoma. But unfortunately, there is no single marker for sarcoma, so we have to consider at least desmin, SMA and vimentin. Next, mesothelioma, and its marker is calretinin. Germ cell tumor is common marker is sulfur, and neuroendocrine, we know synaptophysin and chromogranin. So for establishing a carcinoma, we have to see whether pancytokeratin is positive or not. So pancytokeratin is positive, then CD45 is negative, and S100 is negative. So CD45 negative means it excludes lymphoma, S100 negative, it excludes melanoma, desmin negative, it excludes myogenic sarcoma. So third step is identification of tumor subtype. So if you see this chart, 60% of the carcinoma of unknown primary cases are well to moderately differentiated adenocarcinoma, and another 29% is poorly differentiated carcinoma. So about 90% cases are adenocarcinoma. 5% are squamous cell carcinoma, another 5% undifferentiated neoplasm, 1% is neuroendocrine tumor. So next we have to differentiate the primary. So for breast we use GETA3, for lung we use TTF1 and nepsin, for GI and pancreatobiliary we use CDX2, CA19.9, and for Mullary and PAX8. So in this particular case, EMA was positive, P63 was negative. Now the step 4 or next step is primary localization. And this is the key player, this chart. So we have to depend upon CK7 and CK20. So if CK7 is negative and CK20 is positive, straightforward it is colorectal. And if CK7 is positive and CK20 is negative, it is above diaphragm, and below diaphragm only papillary renal cell carcinoma, ovarian serous carcinoma, endometrial carcinoma, and endocervical carcinoma. If both are positive, CK7 and CK20, it is stomach, biliary tree, pancreatic duct, mucinous, ovarian, and urothelium. And if both are negative, then it is liver, adrenal cortex, renal clear cell tumor, prostate, and non-seminamatous germ cell tumor. So GETA3 negative, CDX2 negative, PAX8 negative, and this is TTF1. TTF1 is positive. CA 19.9 was positive. So in this particular case, whether it is breast is not breast because GETA3 is negative, TTF1 is positive, CDX2 was negative, but CA 19.9 is positive, and PAX8 is negative. So it is primary lung adenocarcinoma. TTF1 is positive, and although CA 19.9 was positive, but we are not considering pancreatobiliary because CA 19.9 can be positive in some lung adenocarcinoma. And another point is TTF1 can be positive in thyroid carcinoma also. So this is the difference among lung adenocarcinoma, pancreatobiliary adenocarcinoma, and thyroid carcinoma. So our case morphology was poorly differentiated. The pancytokeratin positive, so it was epithelial, and it was CK7 positive, CK19, CK20 negative. So it is either adenocarcinoma of lung or breast, upper GI or Mullerian, and as TTF1 positive, so it is lung primary. Now, about molecular advances. So why we do molecular test? Molecular test we do to see if there is any actionable driver mutation. So there are now different methods. We can do molecular test. We can do next generation sequencing. So in case of CAP, what actually happens? What occurs to the primary tumor? So many primary tumor remain diminutive and thus escape the initial detection. It may disappear after seeding the metastasis. And it may be contained or has been eliminated by the body's defense. So these are this one is a malignant small round cell tumor, and CD99 is positive, FLI1 is positive, so it is Ewing sarcoma. So CAP is about 3 to 5% of the total tumors. Fourth most common cause of cancer-related death. Incidence increases with age and is higher in men compared with women. Probability of survival after a diagnosis of CAP is about 20% at first year, and median survival is 3 months. Often presents with early metastasis and poor prognosis. And diagnostic challenge, treatment delay, and limited target options. So histopathological diagnostic goal for CAPs, first is to confirm malignancy. Next, to exclude highly treatable cancers like lymphoma, germ cell tumor. Then predict tissue of origin where possible, and guide targeted therapy when feasible. So thank you very much for your patient hearing.